Hello guys, let me tell you really quickly about enteric fever caused by Salmonella paratyphi. Causes abdominal pain, fever, malaise, and a number of things. Splenomegaly. It causes a lot of things if it is left untreated due to complications in second or third week due to toxemia, bacteremia, septicemia. It is fatal also. Now, what is the pathology? What happens is the bacteria comes into the Peyer's patch of small intestine, divide there, then from there it goes into blood. एसिम्टोमेटिक बैक्टीरियमिया करवाता है, फिर वहाँ से फिर से इंटेस्टाइन में आता है, वहाँ पे लिम्फोइड टिश्यू जो होता है उसके अंदर रहता है, मल्टीप्लाई होता है. मल्टीप्लाई करने के बाद ये क्या करता है कि अल्सरेट कर देता है कभी कभी, जिसकी वजह से ये और ज़्यादा बैक्टीरियमिया, सेप्टिसीमिया, टॉक्सीमिया फैला देता है पूरी बॉडी के अंदर. इंटरसेलुलर ऑर्गेनिजम्स को डिस्ट्रॉय. रिकवरी सिर्फ तब होती है जब उसके सारे ऑर्गेनिजम्स मर जाते हैं. इससे क्या होता है कि जैसे ये जो है दूसरी जगहों पे फैलता है तो सबसे ज़्यादा गॉल ब्लैडर में पहुंचता है. सबसे पहले गॉल ब्लैडर में पहुंचेगा. गॉल ब्लैडर में इन ऑलमोस्ट ऑल केसेस जाता है विदाउट कॉजिंग एनी कोलेसिस्टाइटिस. ये क्या करता है, मल्टीप्लाई करता है वहाँ पे. इसी वजह से हमारा थर्ड और फोर्थ वीक के अंदर हमें स्टूल के अंदर टाइफाइड का जो बैक्टीरिया है ये दिखने लग जाता है. ओके, क्लिनिकल फीचर्स. पहले 5 से 6 दिन में हमें फ़ीवर देखने के लिए मिलता है. फ़ीवर के साथ साथ एब्डोमिनल पेन देखने के लिए मिलता है, एपिक्स्टैक्सिस, ल्यूकोपेनिया एंड ड्राई कफ, ब्रेडिकार्डिया भी देखने के लिए मिलता है. कुछ पेशेंट्स में ऐसा होता है कि स्टेप लैडर राइज होता है फ़ीवर का. अराउंड द एंड ऑफ 1 वीक वी सी रोज स्पॉट्स. रोज स्पॉट्स आर small macules. They are 2 to 4 mm wide and they are red in color, and when there is a pressure they blanch. In 2 to 3 days they are gone. That is why in many people you are not even able to see that there were rose spots, and it go unnoticed in patients. Between 7th to 10th day, what happens is the spleen become palpable in 75% of the patients. There is diarrhea, abdominal distension, bronchitis, and neck stiffness. Maybe confusion starts in patient, and yeah, that's by 7th to 10th. Now by the end of second week you will found that the patient is profoundly very ill. There is a high grade continuous fever. Mental features, you will see confusion, delirium, abdominal pain, diarrhea, and distension becomes remarked. In third week toxemia becomes severe if left untreated, and complications due to widespread involvement of other organs. Patient may become delirious and passes into coma due to typhoid, commonly known as enteric encephalopathy. Okay, so what happens? First 5 to 6 days, fever, headache, malaise, constipation, leukopenia, bradycardia, epistaxis before first week. Between first to second week you will see rose spots, splenomegaly, bronchitis, abdominal pain, abdominal distension, and diarrhea. And beyond second week you will see confusion, delirium, complications like coma. If left untreated you will also see death. Now there is recovery occurs with treatment. Following recovery, about 55% of patient may become carrier भी बन सकते हैं लोग. अब जो पैराटाइफाइड फीवर होता है, इट इज़ लेस कॉमन देन टाइफाइड. पैराटाइफाइड फीवर इज़ ड्यू टू पैराटाइफी बी इन्फेक्शन. इसमें थोड़ी सी माइल्डर इलनेस होती है, टाइफाइड से थोड़ा कम इलनेस होती है. थोड़े छोटे कोर्स के लिए होता है ये. रिस्पॉन्स टू ट्रीटमेंट एंड इंटेस्टिनल कॉम्प्लिकेशंस आर लेस फ्रीक्वेंट. Rash may be more abundant. Clinical features are similar to typhoid. अब relapse कैसे होता है? इसमें क्या होता है कि सारे clinical features within 2 week of initial clinical recovery is considered as relapse. सही हो गया इंसान, उसके अगले 2 हफ्ते के अंदर फिर से वो फीचर्स दिखने लगे तो दैट इज़ रिलैप्स. द रिलैप्स आर यूजुअली माइल्डर, बहुत माइल्डर होते हैं देन जो पहले वाली इलनेस थी. ब्लड कल्चर जो होता है वो नेगेटिव आता है. रिलैप्स जो होता है इसका एंटीबॉडी टाइटर से कोई रिलेशन नहीं होता है. इनिशियल रिस्पॉन्स टू ट्रीटमेंट एंड टाइप ऑफ इन्फेक्शन से भी कोई रिलेशन नहीं होता है. इट इज़ ट्रीटेड एज, जैसे ही टाइफाइड फीवर को ट्रीट करते हैं वैसे ही इसको भी ट्रीट करते हैं, क्योंकि ये थोड़ा सा इसका इंसिडेंस लो होता है ड्यू टू पोटेंट एंटी माइक्रोबियल एजेंट्स बीइंग अवेलेबल अगेंस्ट टाइफाइड. देयर आर मेनी एंटी माइक्रोबियल एजेंट्स फॉर टाइफाइड. Chronic carrier state. So what happens is there is the STIFE, even after the recovery, after in period of 1 year, it is still coming in the stools. अभी ऐसा होता इसलिए है बिकॉज देर इज़ अ persistent growth of typhoid bacteria in gallbladder even after clinical cure of typhoid fever. It is more common in female and is rare in children. Carrier state is potent of infection. Cholecystitis is very rare, but gallstones are common. Okay, laboratory diagnosis. For first week we do CBC. We see normocytic normochromic anemia, leukopenia, albuminuria, and you also see liver and muscle enzymes are mildly elevated. Blood culture is positive, and this is confirmatory diagnosis during the illness prior to antibiotic therapy. The organism can be isolated from bone marrow, blood, rose spots, stool, and intestinal secretion. In second week we do anemia. We see anemia, leukopenia is persistent still, and we do Vidal test, which comes positive and may show fourfold rise in agglutinin against the somatic O antigen. Blood culture may be positive in 50%. In case of negative blood culture, bone marrow culture is indicated. Serological tests like typhoid dot are also done. These tests detect antibody to outer membrane protein or 09 antigen. In third week, you will see anemia and leukopenia are still persistent, and there is leukocytosis in severe septicemia. You will do blood culture. Blood culture is positive in 30 to 40% only. In first week, blood culture was positive in 70 to 90% cases. In second week, it is positive only in 50% of cases. In third week, the blood culture is positive in only 30 to 45% of cases. Positive Vidal test with rising titers in third week. And positive urine and stool culture for STIFE 70 to 80%. Now this only in first week the blood culture okay, it's okay. Complications, systemic disorders, there is the hemorrhage, intestinal में hemorrhage होगा, paralytic ileus हो जाएगा, perforation, peritonitis. In extraintestinal, meningitis, cholecystitis, pneumonia, myocarditis, bone and joint infection, encephalopathy, granulomatous hepatitis, and nephritis. Now the treatment for typhoid is ciprofloxacin, levofloxacin. Either you can give ciprofloxacin or levofloxacin. Ciprofloxacin for 500 mg BID or 700 mg BID in severe cases. Then levofloxacin 500 mg daily. All of these drugs are for 10 to 14 days only. Then you will give cotrimazole 2 tablets, that is 960 mg, 800 plus 160 BID clotrimazole. Chloramphenicol you will give 500 mg 6 hourly, and amoxicillin you will give 500 to 750 mg 6 hours hourly, and then you will give azithromycin 5 mg daily. All of these for 10 to 15. Now what were they? Ciprofloxacin or levofloxacin? Ciprofloxacin 500 BID. If it is severe, 750 BID. Levofloxacin you will give 500 daily. And then we have clotrimazole, clotrimazole 2 tablets, 960 mg, 800 plus 150 mg BID. Then you will give chloramphenicol you will give 500 mg 6 hourly, and amoxicillin 500 to 750 mg 6 hourly, and azithromycin 500 mg daily. Now what is the prevention? Immunization may be used for household contact for travelers endemic area during epidemics. Multi-dose and single-dose vaccines are available, and treatment for carrier state. If you are a carrier and you're not having any fever, you will just, for carrier state there is just ciprofloxacin for 4 weeks, and ciprofloxacin is traditional regimen. Cholecystectomy may be needed in carriers unresponsive to treatment or reoccurrence of typhoid episodes. Thank you.